The first thing is it's very important to understand the nature of insurance and insurance risk and why it's bad for healthcare. This is kind of the root of many of our problems with healthcare. Insurance is a system for managing financial risk, and it's designed for risks that are infrequent, expensive, and unpredictable, like your house burning down from a lightning strike, or getting into an accident and having an untimely death, or things like that. And if the risk does meet those three criteria, infrequent, expensive, and unpredictable, then the main way risk is managed is with risk pooling, where everybody contributes a monthly premium, even though they don't need the help very often. And then for the few people who have a disaster happen to them, the money is there to cover it. And you spread the risk across a large population that's mostly low risk in order to cover the risk for a few people with an expensive, unpredictable problem. To the degree that the risk is predictable, then insurance companies use underwriting and actuarial analysis to try to identify that risk so they can either charge more for it or refuse to cover it, which undermines the whole purpose of health insurance. The problem with healthcare is that way too much of the risk is predictable for this model to be appropriate. Too many people have pre-existing conditions, or you can tell by their demographics how likely they are to get sick, or you can tell by their zip code and their socioeconomic condition how likely they are to have expensive health problems. So there's all kinds of predictable risk in healthcare. So the result is that if you leave the insurance business model to do its thing, they're going to be focused on avoiding risk, excluding sick people, denying care, all the things we complain about, which are built into the business model. So if you have, let's say you have several insurance plans in an area and a new one comes in, if they were to actually offer a better plan, the doctors would find out about it pretty quickly because they're the ones that deal most directly with insurance, and they would tell their patients, oh, this is a better plan. And of course, their patients are the ones that seek healthcare the most, they're the most expensive to care for. They would all sign up for this new, better plan. It would get stuck with a sicker risk pool and end up going bankrupt. So you have a situation creating a race to the bottom, where if you want to compete in the insurance industry, you've got to be no better or a little worse than the competition, or you're going to get killed financially because you get stuck with all the sick people. So whoever bears insurance risk is who has the money and is stuck with covering the variability and unpredictable of healthcare costs. Also, whoever bears insurance risk has the opportunity to make money or lose money off of healthcare. So if an insurance company says, okay, you pay us a fixed amount of money per person and we'll cover the risk, and they manage to avoid sick people, deny care, or what they claim is they're going to be more cost effective, but actually what they're doing is avoiding sick people and denying coverage. But anyway, if they succeed in spending less than the amount of money they got capitated with, they get to keep it. So there is a profit incentive. Even if the insurance company is technically not for profit, there's a profit incentive built into the model of being capitated, which means you're being paid per member in exchange for an obligation to cover the healthcare needs of the population covered. So any payment scheme that holds the provider of care accountable for the cost or outcome of care for a fixed amount per person is a risk-bearing entity. Social insurance is pure risk pooling, which says, okay, we're not going to use a competitive insurance model. We're going to include everyone in the whole population. Everyone contributes through taxes. And the only way risk is managed is risk pooling. And there is no underwriting, no cherry picking favorable risk pools, no exclusion of high risk patients, no gaming of documentation to beat risk adjustment formulas, et cetera, et cetera. Social insurance is pure risk pooling, and that's what single payer is intended to be. So an optimal single payer bill should include one payer that pays providers of care directly with no subcontracting and funding to risk-bearing middlemen, like HMOs, ACOs, and IDSs. We'll get to how you can accommodate a system like Kaiser, which has some positive aspects without it being a risk-bearing entity later on. But you need one payer that pays providers of care directly. You need budgets for institutional providers of care instead of having them bill fee-for-service for every Band-Aid for $10 each and things like that, which happens now with hospitals. So hospitals, nursing homes, federally qualified health centers, they get a budget that's enough to cover their cost of operations, but not enough to build a chain, an empire chain, not enough to retain profit, not enough to pay corporate chain management, but enough to run their operations. And this is not a fixed amount where if they deliver care for less than that, they get to keep the difference, which would make it profit-seeking. It is a budget based on the cost of providing services, exactly like the way we fund police departments, fire departments, and other necessary government services, where you pay them a budget. You pay the police department a budget, but if they have some kind of disaster and have to pay the police a lot of overtime, they're not going to lose money. They're going to ask for a supplemental appropriation. And if they have money left over at the end of the year, they're not going to keep it as profit. It gets plowed into the next year's operating budget. So it's not designed to make money or lose money. It's designed to cover the cost of operations. We should be paying all institutional providers in this way. For independent physicians and other healthcare professionals, we need a simplified, standardized fee schedule that's predictable, where a doctor knows if they do this amount of work, they're going to get paid this much. They can figure out what their overhead is, and they can operate a small business because the payment is simple and standard. And you need negotiated price controls for drugs and durable medical equipment. Those 4 features are for an optimal single payer bill. Something like traditional Medicare is a suboptimal program because it does pay providers of care directly, and it does have a standardized fee schedule, but it's no longer simple. It does not pay institutional providers with budgets, and it doesn't negotiate price controls for drugs and durable medical equipment. So it's got some elements of single payer, but not all of them. So what's the difference between capitation and a budget? Capitation conveys risk, which means there's a fixed payment and you can make a profit if you deliver care for less than that amount of money. And you can't keep unspent earnings and do other things with them than run your operations. And with capitation, there is an incentive to restrict care, to cherry pick and lemon drop. It's all the things that I said are problems with the insurance model. You're being paid like an insurance company if you're being paid with capitation. So like they've capitated primary care doctors here in Hawaii. And the only ones that are making it with capitation are the ones that have large, stable practices of mostly middle-class patients. So they have lots of capitation payments because the practice is large. But they don't have to work too hard because they're a relatively well-to-do population with few complicated problems. If a practice has largely Medicaid patients, they're going to go bankrupt with this formula. And capitation requires risk adjustment. So the supposed solution to this problem is, okay, we'll analyze how sick your patients are and pay you more if you take sicker patients and less if you take healthier patients. So that will counteract the incentive to cherry pick and lemon drop. The problem is that risk adjustment formulas are quite crude. The best of them, the ones most widely used, capture about 12% of the variability in cost, which means there's a remaining 88% of the cherry pick and lemon drop. So it fails to solve the problem because you can't make it accurate enough. And if you try to make it more accurate, that requires very detailed data, and the cost and the burden of trying to gather that data becomes prohibitive. And so the whole idea of let's see how close we can get to predicting risk by using a risk adjustment formula stalls out at about 20% prediction. And beyond that, it fails because it's pushing a rock up a vertical hill. It doesn't work. So you can never get adequate risk adjustment to solve this problem. And this is what the insurance people will all say, oh, we'll just risk adjust so that we don't have this problem. It can't get close to solving the problem. Whereas in contrast, the global operating budget does not convey risk or offer an opportunity for profit or loss.